Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 458 of our pharmacotherapy series, which majors in pediatric malignancies. The next case reads, Job is a 4-year-old Hispanic boy presenting with a 2-week history of an upper respiratory tract infection and a 1-week history of otitis media. His symptoms have worsened, and he now presents with a nosebleed and fatigue. Physical examination reveals appreciable pallor and hepatosplenomegaly. A CBC with differential reveals a normochromic, normocytic anemia with the following: a hematocrit of 15.7%, a hemoglobin of 5.7 grams per deciliter, a WBC count of 4,300 cells per microliter, a platelet count of 13,000 cells per microliter. A differential on the WBC count reveals 82% lymphocytes. The normal range is 30% to 40%, 7% neutrophils. The normal range is 50% to 60%, and 11% lymphoblasts. The normal range is 0%. Based on these findings, a bone marrow biopsy is performed which reveals 95% lymphoblasts. A diagnosis of acute lymphocytic leukemia, abbreviated as ALL, is made. The immunologic class is early pre-B cell based on CD10 and CD19 positivity. Radiography of the chest does not reveal a mediastinal mass, and a lumbar puncture shows that there are no leukemic lymphoblasts in the cerebrospinal fluid. Job is hydrated, alkalinized, and treated with oral allopurinol 200 mg per meter squared per day, with a plan to institute induction therapy the next day. My next questions to you read: within a few days, Job will be treated with several drugs for his leukemia. What is the goal of the induction therapy that Job will receive? The goal of induction therapy is complete remission, i.e., the inability to detect leukemic cells in the peripheral blood or the bone marrow by morphologic microscopic evaluation. Job's peripheral blood values must be within the normal range, and the bone marrow must reveal less than 5% lymphoblasts. This definition also assumes the absence of lymphoblasts in the cerebrospinal fluid, CSF. In addition, based on what is now known regarding minimal residual disease, achievement of a minimal residual disease measurement of less than 0.01% by the end of induction therapy, i.e., day 29, would now be an additional goal of this first phase of therapy. Although these findings indicate an adequate response to chemotherapy, they do not indicate a cure. Most patients have a total of 10-12 cells at diagnosis, and successful induction regimens reduce this cell load by 99% to 109. Therefore, continuation of therapy will be required for JOB to further reduce the leukemic cell population and to increase his chances of long-term survival. Without continuation of therapy, the majority of patients with acute lymphocytic leukemia will relapse within a few months. My next question to you reads: which agents should be used to achieve complete remission? The agents most commonly used in remission induction therapy are vincristine, prednisone, dexamethasone, asparaginase A, peg-aspargis, and daunorubicin. The prednisone or dexamethasone dose is not routinely tapered at the end of induction treatment. Dexamethasone has supplanted prednisone as the corticosteroid used during induction therapy or throughout therapy. This is based on earlier work showing that dexamethasone has greater CSF penetration. In patients with standard-risk acute lymphocytic leukemia, a randomized comparison of dexamethasone to prednisone for induction therapy showed a lower CNS relapse rate in the dexamethasone group. However, the use of a 28-day course of dexamethasone during induction for patients with high-risk acute lymphocytic leukemia was also associated with an increased risk of infectious complications and a vascular necrosis of the joints in adolescent patients. This has led to removal or alteration of dexamethasone use during induction therapy in high-risk patients. It is plausible that the addition of dexamethasone to a more intensive chemotherapy backbone that is used for induction therapy of high-risk acute lymphocytic leukemia may significantly increase the risk of infection in this more myelosuppressive regimen. No chemotherapy drug meets the criteria of an ideal agent, i.e., toxic to leukemic cells only and active in all phases of the cell cycle. Corticosteroids, vincristine, and various asparaginase products come closest to this ideal in terms of activity, primarily against lymphoblastic leukemia, because these agents are selectively toxic to the leukemia cells while sparing normal bone marrow elements. To improve the success in attaining complete remission, additional agents have been added to vincristine, prednisone, and asparaginase. The most frequently used additional agent is an anthracycline, such as daunorubicin or doxorubicin. Use of at least a 3-drug induction regimen is the current standard of care for children at low or intermediate risk of relapse and results in improvements in both remission rate and duration versus less intensive therapy. Currently, a 4-drug regimen, or an even more intensive induction regimen consisting of more than 4 drugs, and often for a duration of more than 4 weeks, is used for children at high risk of relapse and adult acute lymphocytic leukemia patients. If complete remission is not achieved with 3 agents by the end of induction, patients are treated with additional agents, e.g., an additional 2 to 4 weeks of daunorubicin and prednisone, initiation of cytarabine with additional asparaginase, vincristine and prednisone for 1 to 2 weeks. Because this occurs rarely, there is no consensus about the most effective agents or schedules to use in this situation. Most of these patients have a decreased survival and a higher relapse rate. Intensive induction treatment has benefits for the majority of children with acute lymphocytic leukemia. This treatment strategy supports the hypothesis of Goldie and Coldman that intensification of early treatment may decrease the chance that drug resistance will develop. This may therefore increase the proportion of long-term relapse-free survivors. Induction therapy is determined based on clinical findings, such as age at diagnosis and initial WBC count. Based on these prognostic variables, JOB is a patient with a low risk of relapse. A 3-drug induction regimen consisting of vincristine, dexamethasone, and peg-aspargis is recommended to optimize his chances for long-term disease-free survival. Additional laboratory testing, e.g., bone marrow analysis for remission and MRD, will be relied on to design his post-induction therapy. JOB is discharged from the hospital during the second week of induction chemotherapy. Results of his CBC and differential indicate that he is responding well to his chemotherapy, i.e., WBC count 2,600 cells per microliter, neutrophils 69%, lymphocytes 22%, platelets 229,000 cells per microliter, hematocrit of 28.6%, and blastocytes Wre 0. However, during the third week of induction chemotherapy, JOB exhibits severe abdominal pain. It is discovered that he has not had a bowel movement in 6 days. JOB has also been exhibiting acting out behaviors in recent days. How might these symptoms be explained? The use of vincristine is associated with an autonomic neuropathy, which may substantially reduce gastrointestinal motility. In severe cases, paralytic ileus may result. Constipation is often accompanied by colicky abdominal pain, which may be quite distressing. These symptoms usually become apparent 3 to 10 days after drug administration and resolve over several days. Prophylactic use of a stool softener, such as DOC-USET, or laxative, such as polyethylene glycol, may lessen the severity of JOB's constipation and facilitate regular stooling. This regimen should have been instituted soon after the first dose of vincristine. JOB's emotional changes are likely the result of the dexamethasone he is receiving. Emotional lability, sleep disturbances, depressed mood, and listlessness have occurred during corticosteroid therapy in children with acute lymphocytic leukemia. These behavioral changes can be quite disruptive, and parents should be prepared for them in advance. Behavioral disturbances typically resolve within 2 weeks after corticosteroid discontinuation. In addition to the aforementioned drugs, JOB also receives intrathecal, abbreviated as IT, chemotherapy for CNS prophylaxis with methotrexate at the beginning, that is week 1, and end, that is week 4, of induction therapy. So my question to you is, what is the purpose of intrathecal chemotherapy? Intrathecal or CNS preventive therapy decreases the chance of relapse within the CNS and increases JOB's chance of long-term survival. Before CNS preventive therapy was routine, the CNS was the most common site of leukemic relapse and thus predicted bone marrow relapse. Patients at greatest risk for CNS relapse include those with very high initial WBC counts, T-cell acute lymphocytic leukemia, and infants. However, because all patients with acute lymphocytic leukemia are at risk for CNS relapse, one of the largest incremental improvements in disease-free survival has been the routine use of CNS preventive therapy. Because many anti-leukemic agents do not distribute well into the CSF, this area becomes a sanctuary site for leukemic lymphoblasts. The aim is to eradicate any CNS leukemic lymphoblasts present at diagnosis and to prevent the emergence of a relapse within the CNS. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 459.